afternoon, everyone, and welcome to today's webinar presentation on blastomycosis in Ontario, public health and clinical considerations. My name is Jennifer Pritchard, and I am the Enteric Zoonotic and Vector-Borne Diseases Manager at Public Health Ontario, and I have the pleasure of moderating today's session. I would like to start off by acknowledging the lands and waters of the traditional, unceded, and treaty Indigenous territories on which Public Health Ontario operates. We respect and appreciate Ontario is now home to many diverse First Nations, Inuit, Métis, and urban Indigenous peoples and cultures. We are grateful to have the opportunity to work on this land for the mutual benefit of all. Before we begin today's presentation, I'll mention a few housekeeping items. To enhance the presentation experience, participant audio and video functions have been disabled. The chat pod has also been disabled to limit any distractions during the presentation. We are very interested in receiving your questions, so if you do have questions during the session, please use the Q&A pod. A discussion and question period will follow the presentation. And if at any point during this session you experience any technical issues, please email capacitybuilding@oahpp.ca. With that, I would like to introduce the speakers, Dr. Austin Zygmunt, Dr. Anthony Delfa, and Dr. Julianne Koos. Dr. Austin Zygmunt is a public health physician in health protection at Public Health Ontario. He completed his Royal College Fellowship in Public Health and Preventive Medicine at the University of Ottawa in 2021. Since joining PHO in the fall of 2021, he's taken on the role of Public Health Guidance Lead, contributed to COVID-19 consultations and scientific requests, and is the physician lead for monkeypox and blastomycosis. His public health interests include communicable diseases, health equity, and LGBTQ health. Dr. Anthony Delfa is an infectious disease specialist and the interim physician lead for infection prevention and control at Oak Valley Health, which is Markham Stouffville Hospital and Uxbridge Hospital. He completed his medical school, internal medicine residency, and infectious diseases subspecialty training at the University of Toronto. His interests include antimicrobial stewardship, quality improvement, and medical education. When not working, he enjoys spending time with his wife and twin daughters and dreaming about life post-pandemic. Dr. Julianne Koos leads the area of reference bacteriology and mycology at Public Health Ontario's laboratory as a clinical microbiologist and is also an assistant professor in the University of Toronto's Department of Laboratory Medicine and Pathobiology. She has an interest in improving diagnostic methods, antimicrobial resistance, and the epidemiology of infectious diseases, areas in which she has published widely. Julianne serves on several editorial boards for international journals focused on clinical microbiology, as well as national and international committees focused on quality and improvements to diagnostic mycology, including the Institute for Quality Management in Healthcare and the Clinical Laboratory Standards Institute. So our presentation outline for today, we'll be going through a background for blastomycosis, a summary of epidemiology in Ontario, followed by a clinical presentation and treatment, laboratory-based diagnostic testing, and wrapping up with public health management, and then opportunity for questions. With the session today, by the end of the session, we're hoping that participants will be able to describe the expected distribution of blastomycosis in Ontario, understand the etiology, clinical presentation, and diagnostics of blastomycosis, and explain the clinician's role in the management of blastomycosis. And with that, I will hand things over to Dr. Austin Zygmunt.
Thanks, Jennifer. So I'll get us started by going through a bit of background and epidemiology of blastomycosis in Ontario. And so blastomycosis is a disease that is seen in individuals who are infected with the fungus Blastomyces, for which there are two strains, Blastomyces dermatitidis and Blastomyces gilchristi. And these two strains of Blastomyces are thermally dimorphic fungi. So that means that they can change their form depending on the temperature. At 25 degrees Celsius, which represents room temperature or the environment, Blastomyces grow in a mold form where they can produce spores. And at a higher temperature inside the human body, Blastomyces grow as yeast. So you can see in the figure here a depiction of the two different forms of Blastomyces dermatitidis. There are other types of thermally dimorphic fungi that you may have heard of, and these include histoplasma and coccidioides. So we'll go through some basic characteristics of blastomycosis. So transmission of blastomyces is from the environment to humans through the inhalation of spores in its mold form. Blastomyces is not transmitted from person to person. So although it's an infectious disease, it is not considered a communicable disease. So there is no period of communicability for blastomycosis. There is no animal to human transmission. However, there are examples in the scientific literature of infection in animals such as cats and dogs. Blastomycosis has a long incubation period. And so that's the time from exposure to blastomyces to symptom onset. And it is commonly thought of as 3 weeks to 3 months, although the average is about 30 to 45 days. There are several reservoirs for blastomyces that are found in the environment. So one includes soil, examples including near waterways and undisturbed locations, such as under a porch or a deck. And then others include decaying organic matter, such as wood and leaves. In terms of the pathogenesis of blastomycosis, the fungi causes infection in humans when the spores are inhaled into the lungs and they settle in the pulmonary alveoli or the air sacs. And this can cause an inflammatory response. At the higher human body temperature, blastomyces will grow in the yeast form, as I noted. And Dr. Delfa will get into this in greater detail, but this infection can be localized into the lungs, and it can also be extrapulmonary, meaning that the disease is outside of the lungs where the yeast is spread through the bloodstream to other parts of the body, such as the skin and the bones. For risk factors for blastomycosis, anyone can become infected with blastomyces if they've been to an area where it is in the environment. And there are a variety of activities that can increase one's risk of becoming infected, which I'll speak to in greater detail in the public health section. But some examples include activities that disrupt the soil, such as gardening, or participating in activities that are in wooded areas, such as camping and hunting. We also know that individuals who are immunocompromised are more likely to develop severe blastomycosis. So in the next few slides, we'll go through the epidemiology of laboratory confirmed blastomycosis in Ontario. And the source of the data for all of the slides is the Integrated Public Health Information System database known as IFIS. And the data period will be from January 1st, 2018 up until we pulled the data on August 10th of this year, 2022. So this first figure shows laboratory confirmed cases of blastomycosis by gender in Ontario, with blue representing males and green representing females. And you may have heard a common feature reported with blastomycosis is that there's a seasonality with infection. And the thought there is that people get exposed and infected during outdoor activities in the summer months or early fall. And then due to that long incubation period that's up to 3 months, they present in later fall and through the early winter. And so although we don't have any statistical analysis in this graph, visually, when you look at it, you can see a general pattern of perhaps some higher numbers of cases that are reported in late fall and early winter months, and perhaps some lower numbers reported in the late winter and early spring months, but that's certainly not the same trend in every year. You will note that overall there are more infections in males than females, and you will also note a large increase in the last quarter of 2021, and that was in association with a large blastomycosis outbreak in Northern Ontario. This table depicts the severity of blastomycosis in Ontario, which is defined as hospitalizations and deaths. And here we present the total number of confirmed cases and then the proportion of confirmed cases in that year that had that outcome. So you can see that of the confirmed cases in Ontario, there's quite significant severe disease requiring hospitalization. This can typically range from 35 to 50% in any given year, and deaths ranging from 5 to 12%. I will note that the data for this year is incomplete, given we are still in 2022, and we typically see more cases into the fall months. The final slide we'll go through with epidemiology is the blastomycosis rate per 100,000 population by public health unit. And you can see that the highest rates, which are in the darkest shade of blue, are in Northern Ontario. But there is still significant numbers through Central and Eastern Ontario, which are all in that medium shade of blue. And then the lowest rates of blastomycosis appear to be reported in Southwestern Ontario. So I'll now hand it over to Dr. Delfa, who'll go through the clinical presentation and treatment of blastomycosis.
Great, thank you, Austin. And hi, everyone. So in terms of the clinical side of things, part of the reason why not just blastomycosis, but many of these dimorphic fungal infections are quite humbling, even to infectious disease specialists, is because they can be quite variable in their presentation. They can infect many different organ systems, and they often get confused for other clinical entities. Many of the symptoms, again, being nonspecific, often lead clinicians down a path of what is typically a more common diagnosis, and then it's not until several weeks or months later that they realize what the diagnosis is. And I thought it would be most helpful to actually go through a list of clinical features, but then also explain through a variety of cases just to see how diverse this infection can present. So as Austin mentioned, because the primary source is inhalation of spores, pulmonary involvement in the lungs is by and far the most common manifestation of blastomycosis. And you can see from the list there, the symptoms can be quite variable. Some present with a non-resolving cough, fevers and other infectious symptoms. Sometimes it's sputum production. Some people have more constitutional symptoms, meaning they have night sweats, weight loss, hemoptysis, which means you're coughing up blood. And like Austin mentioned, it can be 3+ weeks from the time that you're exposed to start even developing some of these symptoms. You'll notice less commonly, but possible, are other extrapulmonary involvement that we call it, which just means anything outside of the lungs. The next most common is actually skin lesions, which again, the theory is one of two ways: either direct inoculation on the skin from the spores, or after you've had it in your lungs, it then disseminates, which means it goes into your bloodstream, as Austin mentioned, and then from the bloodstream, pieces of the fungal organisms can then go into your skin and other organs. With the skin, you can have a variety of lesions, but commonly you get what's described as a verrucous lesion, which means it almost looks like a wart in nature. Sometimes you actually get ulcers, which are opened areas of skin, and sometimes you get nodules that look like they're under the skin and haven't broken open yet. You can get involvement with the bones and joints, so we call that osteoarticular blastomycosis. As well, in rarer situations, you can get genitourinary effects, which could include prostatitis in the bladder. Rarely, you can get tubo-ovarian abscesses, etc. And then one other entity that's important to note is you can get central nervous system infection. That's what CNS stands for, in which case you can present with a clinical feature like meningitis. You could get abscesses either in the brain, but also in the epidural space, which is in between the spinal cord and the spine. So you can see many different organ systems can potentially be involved. The percentages won't add up to 100% because some people who have disseminated disease will have multiple different areas involved. Now, going through case, I think would be helpful just to illustrate the wide spectrum of illness and how this can present. So the first case, and these are all actually from my own outpatient clinic, so just a rough sampling of what we could see in our local area. This case was a female, actually a teenager, previously healthy. She was a high school student, also worked part-time at a fast food restaurant, but denied any of those classical exposures that Austin alluded to, not really one to go outdoors, no hiking, camping, etc., doesn't garden. And she presented to her primary care provider with a non-resolving cough that lasted for a few months. There was intermittent blood seen in her sputum as well. She ended up going for investigation, which included a CT chest. It did show a mass-like consolidation. The radiologist seeing that said, despite her young age, this looks somewhat like a malignancy, so an urgent respirology referral is recommended for bronchoscopy. She ended up having the bronchoscopy, and it wasn't until the culture came back and the culture confirmed Blastomyces dermatitidis growing. But you can see in this case how, again, it got confused for either a non-resolving pneumonia or like a bacterial pneumonia instead of a fungal pathogen, or actually looking like almost like a malignancy. The next case, this was a man in his late 60s, a few pieces of past medical history, but no previous respiratory illnesses. He actually lives in a large farm, a plot of farmland just to the east of the Greater Toronto area. Him and his spouse traveled extensively around the world. He does frequent gardening, so he had some more likely exposures. And his story is a bit more convoluted, but initially had what was essentially non-resolving skin wounds, which he thought were actually insect or wasp bites that weren't resolving. It also included a large wound in his groin, which was assessed by a surgery department, ended up having to be debrided. Didn't seem to respond to multiple courses of antibiotics. And then to throw a curveball, the wound was swabbed. It grew a bacteria called Pseudomonas, which is historically resistant to some antibiotics. That was felt to be the reason, was put on appropriate anti-pseudomonal antibiotics, but still wasn't fully resolving. What was noted eventually, one of the lesions that was actually on his finger eroded down to the bone. So he was able to have his bone debrided, and that bone culture is ultimately what grew Blastomyces on the fungal culture. And it wasn't until he was actually placed on appropriate antifungal therapy that all the lesions eventually resolved. The next case, a woman in her 40s, again, previously healthy. She prides herself on being the least outdoorsy person you will ever know. So again, none of the classical risk factors or exposures that she was aware of. Lived in a relatively suburban area, not much farmland, no significant soil exposure. Her presentation, similar to the first case, was more of a respiratory picture where she had an intermittent dry cough, again, about 3 months was going on, was investigated by her primary care provider, and eventually was transferred to a respirologist. And once again, interestingly showed a mass with consolidation, this time also a small pleural effusion. There was again a query of possible lung cancer. There was a potential, because there was a possibility of lung cancer, there may have been a superimposed bacterial pneumonia, didn't respond to 2 different courses of antimicrobials. She eventually had to come to the emergency department and was admitted due to the worsening respiratory symptoms. She just so happens to have had a bronchoscopy as an outpatient just prior to her presentation. And on the pathology, there were fungal organisms that looked like Blastomyces that were seen on the pathology. And eventually, Blastomyces also grew on her culture. So once again, it mimicked other conditions as well. She was initiated on antifungal therapy that evening. She did require oxygen, so she was actually placed on intravenous antifungals, which we'll talk about in terms of treatments now. So what we use for our treatment guidelines is essentially the IDSA, or the Infectious Diseases Society of America guidelines on blastomycosis. It roughly, it's several pages long, but it could be split up roughly into pulmonary versus the extrapulmonary involvement. Some people with pulmonary involvement, like our first case, have very mild illness, no impact on their quality of life, no supplemental oxygen, not needing to be hospitalized. You could be treated with an oral antifungal agent for roughly 6 to 12 months, depending on the nature of your symptoms, how quickly it resolves. If somebody presents with more severe infection, meaning they're requiring supplemental oxygen or they're developing hypoxic respiratory failure, we do have some rare cases that end up developing ARDS, which is acute respiratory distress syndrome, end up in the intensive care unit quite ill. Those patients would receive 1 to 2 weeks up front of amphotericin B, which is an intravenous broad spectrum antifungal. And then once there's clinical improvement, they could be transitioned to one of our 2 more classic oral agents, which is either itraconazole or voriconazole. For extrapulmonary, you can see some of the examples here, but roughly the same in terms of guidance. Mild, you're looking at an oral antifungal for 6 to 12 months. Severe, you get the IV up front. There's a specific note for osteoarticular, which again is bone or joint involvement. You err on the side of at least 12 months because it's quite a deep-seated infection. Shorter durations are associated with treatment failure. In the central nervous system, so in the brain or spinal cord, not all antifungals penetrate the central nervous system. And so you're often on the amphotericin B for a longer period of time to make sure enough is penetrating into the central nervous system. I mentioned itraconazole, which is our go-to first-line agent. It's been around for many, many years. Just some pearls, if you do end up needing to prescribe this medication or you need more information about it, it now comes in 2 different formulations. There's an oral suspension, which tends to actually have a better bioavailability. The capsules actually do quite poorly in terms of their availability. So in general, the oral suspension is much more highly favored. However, no matter how you take it, GI or gastrointestinal intolerance is very common. Significant nausea and vomiting can be associated with itraconazole. You do require a specific blood test to check the therapeutic level of itraconazole in your bloodstream around 2 weeks on therapy. You want to be above a certain threshold to make sure it's at a therapeutic level, but too high of a level, you could accumulate toxicity, and it helps you dose it appropriately. Itraconazole is one of the antifungals that has poor penetration into the brain or spinal cord, however. So this is back to case 3, where we mentioned the woman who was admitted with supplemental oxygen, found blastomyces in her bronchoscopy, did get amphotericin up front, was doing better, was transitioned to itraconazole. She could not tolerate more than 6 months. I mentioned we treat 6 to 12 months usually. At 6 months, she felt back to normal. She felt very well. She was off oxygen. She was caring about her usual day-to-day activities. So it was decided that the patient did not wish to have any more medication, stopped at 6 months. However, interestingly, shortly after stopping, she began to notice intermittent headaches, as well as some visual changes that went on for about a month, which significantly worsened. And around Christmas time, she ended up presenting to an academic institution, and an MRI was concerning for a potential abscess. Sure enough, she went to the OR. She had a craniotomy and evacuation of the abscess, and fungal culture from the brain abscess ended up growing blastomyces. So unfortunately, as I mentioned, itraconazole, which we thought was only needed to be treating pulmonary infection, she actually developed central nervous system infection. Likely before that, before itraconazole was initiated, it had disseminated up to the brain, and it had no, the brain abscess did not have any exposure to antifungals because itraconazole, again, doesn't penetrate very well. So what we need to do is put her on a central nervous system active antifungal. We tried voriconazole, which is another oral antifungal that has excellent penetration into the brain, the spinal cord, and the eyes. However, she had very severe visual and neuropsychiatric side effects from this medication. So unfortunately, that had to be stopped as well. So again, some other treatment pearls. We mentioned fluconazole, which is most people's go-to oral antifungal for most fungal infections, but unfortunately for blastomyces does have high rates of failure due to resistance rates. Itraconazole, like I mentioned, generally is our go-to for anything outside of the brain, but can't penetrate the brain or spinal cord. Voriconazole is quite a good antifungal, but in unusual cases, you can get quite severe visual side effects, which includes blurry vision, but also other visual hallucinations, including very vivid color hallucinations as well. And that could indicate that you're intolerant to the medication, or you have toxicity, meaning your serum level is too high. The echinocandins, which are caspofungin, micafungin, anidulafungin, you may have heard of these agents, they actually have poor activity against blastomyces, so they're not an ideal agent to use. And then amphotericin B, again, is very broad spectrum. We'll definitely cover it. However, amphotericin B, logistically very challenging to administer because it's intravenous, high rates of kidney issues, electrolyte abnormalities, and it does require inpatient admission for monitoring. And a prolonged course is typically not feasible to give. So in her case, we ended up giving her a new azole antifungal called isavuconazole. It's been around for only a couple of years now, but it's an oral agent. It's once daily. It's very well tolerated compared to the other medications, and it's felt to have very good central nervous system penetration as well. Studies have shown that it's at least non-inferior or superior to some of the other highly effective oral antifungals such as voriconazole or posaconazole. The downside, because it's a new medication, it's quite expensive. And for blastomyces specifically, there's actually not a lot of published data on it. So in terms of trying to get the exceptional access program or some kind of medication coverage was quite a hurdle to overcome. Fortunately, in her case, which unfortunately won't be the case in other people, she had private drug coverage through her spouse, and that was essentially the only way we were able to logistically get this medication for her. Otherwise, you can imagine we would have actually been stuck without a good treatment option that she would be able to tolerate that would actually help to finish treatment for her brain abscess. So with that, I'll hand it over to Julianne to discuss laboratory-based diagnostics.
Thanks, Anthony, and good afternoon. So as you've seen from Anthony's slide, blastomycosis can be very difficult to diagnose. So I'm going to go over some specific laboratory tests that can be used to aid or confirm a diagnosis of blastomycosis. I'm going to go over each of these in greater detail in the following slides, but just as an overview, the tests that we'll talk about are traditional microbiologic tests, so microscopic examination and culture of the patient's specimens. Histopathology, so microscopic examination of specimens that go to pathology labs. There are serologic assays, antigen-based assays, and I often get questions about molecular assays, which is the direct molecular detection of blastomyces DNA from specimens. So currently there are no Health Canada or FDA approved assays. Some labs do offer laboratory developed tests, but they're not very widely available. And because of this, I'm not going to talk about these particular tests today. So specimens sent to the microbiology lab are examined for the presence of fungi in the sample. And growth of blastomyces, the fungus, from a clinical specimen is considered a definitive diagnosis of blastomycosis. These procedures can be done on any type of specimen, and culture of blastomyces is considered the gold standard test for diagnosis. And like was mentioned, most of the specimens that we receive are sputum or BALs, given that most symptoms are respiratory. And depending on the report, culture is determined to be around between 66 and 90% sensitive for respiratory specimens and about 77% for extrapulmonary samples, with the specificity of these tests being 100%. So what happens in the lab? What's the process? Some people are frustrated by the length of time these tests take, so I'm just going to walk through what happens. So specimens arrive and are set up for a microscopic examination as well as for culture very soon after specimens arrive. The slides are read in most cases within 24 hours of receipt at the lab, and they are examined for the presence of fungal elements. So blastomyces has a very characteristic appearance. You saw in those early slides, it's a large, broad-based budding yeast. These are much larger than Candida species and very, very characteristic. So if these are observed in the specimen, a report can be issued that same day, usually something to the effect of broad-based budding yeast resembling blastomyces. And that's issued as a preliminary report and can be done pretty quickly. The culture, on the other hand, will take a little bit longer. So culture plates are set up and examined regularly for up to 4 weeks. Once the growth is observed, which in most cases would happen within 10 days for most specimens that we process, those cultures are examined to see if the mold or the fungus that's growing looks like blastomyces. And identification of that fungus is confirmed with a molecular probe or sequence analysis, and this will provide that definitive identification. And I just want to note here also that blastomyces, Dermatitis and Gilchristei, are risk group 3 organisms or pathogens, and the cultures must be worked up in special containment level 3 laboratories, which is why in Ontario, these samples for culture are all forwarded to the Public Health Ontario Toronto Mycology Lab, where we have access to that specialized lab environment. So another approach to the diagnosis of blastomycosis is serology, or the detection of antibodies, the bodies made against blastomyces. So the specimen here is blood or serum, which is fairly easy to collect. However, it's important to note that antibodies can take weeks to develop after exposure or infection. And additionally, presence of antibodies when they are detected is not considered definitive evidence of infection, but rather presumptive evidence that the patient was or is currently infected with or was exposed to blastomyces previously. There are multiple laboratory methods for performing this testing. So these include traditional methods like complement fixation and immunodiffusion. These are very manual assays that require considerable technical expertise, as well as there are newer enzyme immunoassays. So here at Public Health Ontario, we use the immunodiffusion assay, which is reported to have a specificity of 100%, but a sensitivity between 32 and 80% depending. The EIA is more automated and more sensitive with slightly lower specificity. It's an excellent test, but currently this assay is not available in Canada. So some things to consider regarding serological testing results are that they're not recommended to be used in isolation for clinical diagnosis or patient management. The results really have to be used in combination with other test results. It's possible that samples may be collected too early, so you don't have a strong enough immune response, and the body may not have had time to develop those antibodies, so the test may be negative, even in those with blastomycosis or blastomyces infection. So in those cases, repeat testing in 1 or 2 weeks may be helpful. And on the converse, antibodies can persist for quite some time, even after the resolution of infection. Additionally, some immunocompromised patients may fail to mount a proper immune response, resulting in negative tests. So for serology assays in Ontario, the turnaround time for these is about 1 week. And finally, I'm going to talk about blastomyces antigen detection assays. These are, there's quite a lot of interest in these. These assays detect small components of the fungus in various specimens, including BAL, serum, CSF, and urine. And urine is a really attractive specimen type as it's non-invasive, easy to collect, and it can be potentially very useful in patients where it's difficult to get a good sputum or a BAL specimen for microscopy and culture, or in those patients where you're investigating non-pulmonary disease and want to avoid a biopsy. The test is quite sensitive with reports around 89 to 93%. There are a couple drawbacks though. One being in regions with multiple endemic fungi, like Ontario is. There is a very high degree of cross-reactivity of this assay with other fungi, including histoplasma, which can result in false positives. And the other drawback is that this assay is performed in less than a handful of labs, none of which are in Canada. So this assay is a send out to the United States. So this is a very busy slide. I've put together some test performance characteristics here, highlighting test sensitivity, specificity, approximate turnaround times, as well as test strengths and limitations. I don't expect that you will be able to see or read all of this, and these slides will be available afterwards for your reference, I'm told. But I just wanted to highlight that no one test is perfect and each have pros and cons. And for the ordering physician, it's very important to know these strengths and limitations when ordering the test and interpreting the results from the lab. So in summary, we have culture and microscopy. Culture remains the gold standard for diagnosis. Microscopy can be microscopic examination of the specimens can be very rapid. However, the culture and confirmation can take weeks. For serology, the assay used in Canada is not very sensitive, but is highly specific. And it's not a really suitable test for acute diagnosis or for some immunocompromised patients. For antigen testing, where rapid diagnostic testing is needed or collection of specimens is challenging, antigen testing can aid in diagnosis. It's very sensitive. However, there's lots of cross-reactivity with other fungi, including endemic fungi. And antigen testing is a send out to the states arranged by the treating physician or that laboratory. And PHO is able to support in the context of an outbreak. So in terms of final recommendations, diagnosis is very challenging, and given each test limitation and strength, a combined diagnostic approach is really necessary. So that includes microbiology-based investigations. And I would advise, really, where possible, to submit multiple specimens for microscopy and culture per patient to increase time, or over time to increase sensitivity. So that means multiple BALs or multiple sputums. And as a special note, the specimen quality is very important. A poor sputum specimen, which is mainly saliva, is not an adequate specimen for diagnosis and can lead to false negative results and delayed diagnosis. So I think we're going back to Austin now.
Thanks, Julianne. So I will finish the presentation by going through the public health management of blastomycosis. So this is a reminder to the clinicians on the call today that blastomycosis is listed as a disease that requires reporting to your local public health unit under the Health Protection and Promotion Act. And amongst the list of reportable diseases, there is a list of specified diseases that require a clinician to immediately notify their local public health unit so that an urgent public health action can be taken. And examples of that include invasive meningococcal disease or hemorrhagic fevers. And when this immediate notification is done by a physician for the specified disease, the billing code K034 can be used. However, for blastomycosis, this is not on that list of specified diseases. So although it requires public health unit notification, this can be done on a non-urgent basis by the next business day. And so reporting blastomycosis is not eligible for this billing code. The case definitions for blastomycosis are found in Appendix 1 of the Ontario Public Health Standards Infectious Disease Protocol. And I provided a link to this resource in the end of the presentation. The confirmed case definition requires laboratory confirmation of Blastomyces species. And so that's either by culture or through nucleic acid amplification, as Julianne noted. And then the probable case definition is also using lab-based criteria, but is based on visualization on microscopy of those large, broad-based budding yeast, which, as Julianne noted, is a classic characteristic of Blastomyces. Appendix 1 also notes the considerations for blastomycosis outbreak and provides some thoughts on when to consider an outbreak in an endemic versus a non-endemic area. So in an endemic area, this would be an increase in blastomycosis case numbers above the expected level. And in a non-endemic area, this would be 2 or more cases linked to a common location. I think the key point here is that if a public health unit has a concern about a potential clustering of blastomycosis cases or for an outbreak situation, they should consult with us at Public Health Ontario, as well as our colleagues at the Ministry of Health. And so we can review the situation and help prepare outbreak-specific case definitions, such as a confirmed, probable, and suspect case definition. In terms of the case management of blastomycosis, one important aspect is treatment, which Dr. Delfa outlined, and that treatment is under discretion of the attending healthcare provider. From a public health unit follow-up perspective, conducting a detailed follow-up of a case is up to the discretion of the public health unit. And it's particularly important to do this in areas that are not known to be endemic for blastomycosis, as it helps us to better understand the provincial surveillance and new areas, new risk areas for blastomyces. For contact management, there is no required contact management, as there's no person-to-person transmission. One exception to this may be if a public health unit becomes aware of a common source of exposure where other individuals were potentially exposed. They could advise asymptomatic individuals to monitor for signs and symptoms of blastomycosis and to seek a clinical assessment if they develop symptoms. So in these next couple slides, I'll go through the case investigation. So for any case investigation for infectious disease, there's some routine information that's collected, such as the case details, their demographics, like age and gender, and their address. And then some specifics for blastomycosis would be to look at medical risk factors. So we're interested in knowing their immune status, as well as if they have underlying cardiac or respiratory disease. And then it's important to conduct a thorough symptom list, given the wide clinical presentation of blastomycosis. Of course, we're also interested in key clinical information and outcomes, such as requiring a visit to an emergency department, severe disease leading to hospitalization or ICU admission, what treatment the case received, and then any fatal outcome that is reported. One of the key components of the case investigation is focusing on a very detailed history to determine any potential sources of exposure to blastomyces in the 3 months before the case developed their symptoms. So this includes asking questions about their exposure to soil and wood. So asking if they've been to a wood pile or chopping wood or digging holes or gardening as examples. But it's also important to ask about activities that an individual may not necessarily associate with an exposure to soil or wood. So an example of this would be visiting a beaver dam where decaying wood would be present, or partaking in outdoor activities such as ATVing or hiking that might disrupt the soil. And then public health units can also ask other types of questions to get at other potential sources of exposure. So being at a location with a dirt basement or visiting a cemetery as examples. And so during your case investigation for blastomycosis, if you have any questions on the types of sources of exposure you should be asking about, please reach out to us at PHO and we can help assist with the case investigation form. So on my final slide here, we'll go through environmental testing for blastomyces. And this is a common question that comes up during a blastomycosis case or outbreak investigation. Really asking, what is the utility of doing environmental sampling to identify the potential source of infection? And so testing the environment is not something that is routinely recommended. Previously, this has mostly been done for research purposes and has been largely unsuccessful in isolating blastomyces in the environment. However, in some instances, environmental sampling is done, but is not necessarily reassuring. So if a negative test comes back, it doesn't rule out the presence of blastomyces somewhere else in the area. And if a positive test comes back, it doesn't necessarily mean that that was the source of infection for that case. And so with that, that's the end of our presentation slides. I'll hand it back over to Jennifer to moderate the Q&A.
All right. Thank you so much to Austin, Anthony, and Julianne. So we will now move into the Q&A pod to address some of the questions that have been received. So just a reminder to those on the webinar, please continue to answer your questions into the pod if you haven't already had an opportunity to do so. We will do our best to go through the questions. I may go through some of them that I see some of our panelists are answering as well, just to make sure everyone's able to see the responses as well. So I think we will start with our first question around, is there, so I'll sort of open this, I guess, to all of the options. Sorry, the questions are flying in here. So I'm not sure who would be best able to answer this question, but there's a really interesting one about what proportion of people who are exposed to blastomyces actually end up with symptomatic disease.
I think we'll never know that answer because it's very ubiquitous fungus that's all over. And so what we're seeing is probably just the tip of the iceberg of who's actually exposed, who ends up. So it could be a very small proportion, especially like the cases that we had. We actually couldn't identify where some of the patients got their exposure from. And so we think that there's likely a lot of exposure, just your immune system fends for itself for the vast majority of cases. So likely it's actually a small proportion.
And not all people who are exposed are going to become infected, and some may have just very mild illness that resolve, like it's self-resolving, so they may never, present to a physician, and it's just never recorded. So I agree with Anthony. I don't think we'll ever know.
All right, thank you so much. So sort of sticking along that theme, there is an interesting question. I'm not sure who would have some insight into this, whether it's known, is around the average time for diagnosis in Ontario, in thinking about the complexities of the illness in and of itself. And I don't know if there's anything, recommendations about how that could be reduced to help out with exposing patients to various treatments.
I can start and say likely at least several weeks, if not, as seen in the cases that we had, could be months, where, again, like Julianne mentioned many times, these symptoms are quite non-specific. They could be a viral illness with a post-viral syndrome, and many people with a non-resolving cough will eventually be assessed. They'll have something like postnasal drip, or they'll be assessed for GERD, other conditions. And it's that very, very small percentage that happen to have a true atypical infectious cause. And that's why not everyone with a cough that lasts for 4 weeks will go to a bronchoscopy right away. And so this is where it's a bit more challenging. And perhaps if they're known to have high-risk exposures, or they are in a higher risk area like northwestern Ontario, as was alluded to, that could increase your pre-test suspicion that you might be more likely to have it if you have typical non-resolving respiratory symptoms. But otherwise, that's what poses the main challenge, is the radar is not on, likely until a subspecialist gets involved, when they ruled out the more common causes, which would be a respirologist, infectious disease specialist, etc., which that tends to take weeks to a few months.
Maybe I can jump in as well, Jennifer. And so this is not something that we've looked at to date, but there is the ability in our integrated public health information system, IFIS, to look at time from date of symptom onset to date of diagnosis. So we can take that back and see what type of analysis can be done from a Public Health Ontario perspective.
Okay, great, thank you. One of the questions as well was around photos of lesions. Anthony, do you know of an easy place where people would be able to find photos?
There are some dermatology websites that are accessible by internet search that will likely have something to that extent. There are some scientific journals as well that have some case reports of photos. For the purposes of this presentation, we can't include things that are proprietary to other published pieces, but they are searchable on some other resources as well.
Thank you. Another question is, if you've had blastomycosis before, are you more at risk to get it in the future?
It speaks more to the reason that you acquired it. So if you're still in a very high risk environment and you could be re-exposed to it, the likelihood of getting it a second or third time, it's not really well established, mostly because it's so uncommon. Whether the antibodies you create will fully protect you from another infection in the future, it's difficult to know. I don't know if it's really been described about a second infection, whether that speaks to once you've had it once, your antibodies are fully protective, or again, just because those that go on to true symptomatic infection are the tip of the iceberg, the likelihood of you doing that a second time is very uncommon. Would be basically the two clinical reasons why it's extremely unlikely to get a second clinical blastomyces infection.
Thank you so much, Anthony. So there was a laboratory question I wanted to make sure to cover in terms of shipping specimens. When sending a sample to the lab, do we need to alert the lab beforehand that we have a suspect blasto?
So if you're shipping a specimen, there's no special notification required. We do ask that if you have a queried blasto culture from a microbiological plate, that you give a heads up that it's coming, because it is that risk group 3 organism.
Thank you, Julianne. Another question. So is the public health management of blastomycosis strictly about collecting epidemiological data? Does this data inform any interventions that health units can take to reduce risk of infection?
I can take that one. And so I think collecting the epidemiological information for a blastomycosis case, what the key part there is to try and determine where a potential source of infection may have been, noting you're really looking over a wide period of time, that 3 months from when they could have been exposed up to when their symptoms began. And then the importance there is if you're having multiple cases of blastomycosis and trying to find a common source between them, which might be able to provide some additional information. So really the key piece from a public health perspective is really to try and bring that epidemiology information together to help inform where blastomyces may be occurring in Ontario.
Thanks, Austin. Another question along that line was whether there were any thoughts on linking with canine blasto surveillance for understanding changing risk areas.
Yeah, it's certainly an interesting thought. It's not something we've done at Public Health Ontario to date, but something we could follow up with our veterinary colleagues to see what type of information may be available. One part of the case investigation for blastomycosis is to ask about your pets or animals that you have, and like a dog with a cough, for example. And that's not because of any animal to human transmission. As I noted, that's not something noted with blastomycosis, but the thought is there potentially a shared source of exposure that your pet may have had? And that can help inform the investigation as well.
Thank you so much, Austin. So this question has come in a few times, so I want to make sure we get to that one. And it is around prevention recommendations or preventative measures that can be taken.
So I can start, and then maybe Dr. Delfa can jump in as well. It's a tough one to provide recommendations to mitigate your risk of acquiring blastomyces infection. I think a key piece would be if your public health unit has identified areas where it's endemic in the environment, that's probably where I would recommend targeting risk communication. And then it's really around the types of activities that might lead to one's exposure. So we provided a long list today, but just some routine messaging you can give to help protect yourself from activities that might disrupt the soil or exposure to wood. And blastomyces is certainly one infectious disease, but there are others. And so I think if you're looking to provide specific risk communication to residents in your health unit and need some assistance in developing some messaging, that's something you could reach out to us and our Ministry of Health colleagues as well to help develop.
Yeah, I'd agree with that. I think it's from an individual risk mitigation, it's challenging because it's more day-to-day activities in the right area with the right sort of amount of fungus will be what will predispose you. And, it's, a bit much to ask people to wear a respirator while they're gardening, for example. Like, it's not really realistic in terms of some of the recommendations, because again, as we saw in our cases, people who have none of the typical risk factors ended up having infection. So there's not really anything that we know of that are specific risk features, unless, like Austin mentioned, your public health unit is known to have a very high number of cases in the local region to be aware of it. If that, influences people's decision to do excessive gardening or etc., we may reduce your risk, but won't eliminate the risk necessarily, especially if something like local construction projects, things that will sort of disrupt the soil, whether you do anything about it or not, will impact that as well. So this is one of those tougher ones to individually lower your risk. And it's one of those issues where an entire community could potentially be exposed. And again, just a very, very small proportion will end up with some kind of clinical manifestation.
Thank you both so much. So there is a question around whether there's a standardized case investigation form available from PHO for Blasto.
So this is something that we're working on at PHO, and with the large outbreak that occurred in Northern Ontario last fall, we did assist the public health unit in developing a case investigation form at the time. And although that's not formalized, if there is some assistance that your public health unit requires in investigating a case of blastomycosis, or you're concerned about a cluster of cases, please reach out and we can share that resource with you.
Thank you so much, Austin. There's an interesting question, Julianne, around whether WGS analysis would be a suitable approach to gain additional knowledge for treatment, and is WGS investigation commonly conducted, or is this type of analysis more rare?
So that is not commonly done at this time. I don't believe that it has a really large role right now as a diagnostic. Right now we're at PHO, we are using it as an investigative tool to help understand the epidemiology, the genomic differences between isolates that we receive in the province. But I don't think it has a really large role as a diagnostic tool at this time. But it, we're hoping that it will shed some light in terms of understanding the distribution and diversity of the organism throughout the province. But it's not routinely done at this time.
Thank you so much, Julianne. So at this point, I will take this time to wrap things up. Thank you so much to everyone with the submission of the questions. We as well will take these back and consider, where these questions are taking us, and perhaps liaise with some of our external partners as well, for just to let them know about some of the interesting questions that we're receiving. So as we wrap up today's webinar, I would just really like to take a moment to thank so much to Dr. Austin Zygmunt, Dr. Anthony Delfa, and Dr. Julianne Koos for presenting. I would also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access past presentations and view confirmed upcoming sessions, please visit the PHO website. You can head to Education and Events and click on Presentations, and that too will be where you'll be able to find this presentation once it is posted. And with that, I really just say thank you to all and have a wonderful day.